Thanks. Good morning. Thanks for the opportunity. We have got a very interesting session from top-class experts on a practical dealing of the meniscus. May I invite Dr. Shyam Sundar to guide us on what to do with the mucoid ACL.
Good morning all. Thank you, respected moderators. So my talk is on discussing about the treatment strategy for mucoid ACL. We all know that it's not that rare, but we do come across in all age groups, but most commonly between 40 to 60 years age group. The basics of mucoid degeneration is it's just infiltration of the synovial tissue into the ACL collagen, which produces a mucinous substance and then changes the entire nature of the collagen. So it can be a synovial theory or traumatic theory or degenerative theory, whatever it is, there is alteration in the collagen and it becomes quite bulky, and that's the one which is going to cause symptoms. It can be seen in asymptomatic cases also. I mean, in one study, 50% of the ACL cysts were asymptomatic. So don't go into operating any asymptomatic mucoid ACLs. Watch out for other conditions, associated conditions, which are the main reason for these symptoms. The most important clinical presentation the patient presents with is anterior or posterior knee pain, restriction in flexion, restriction in extension, combined flexion and extension restriction, and those are the main symptoms. And only an MRI will finalize your diagnosis. In the MRI, you have a classical celery stalk appearance, and most commonly these mucoid ACLs symptoms are also associated with chondral damages, which accounts to around 82%, and meniscal lesion, which accounts to about 69%. So there's a combination of conditions which is leading to the symptoms. This is a classical MRI picture of a celery stalk appearance, and arthroscopically it looks like a degloved. No? The synovial envelope is missing and the collagen is fragmented. So these are the classical findings that you see in case of mucoid degeneration. There are various treatment options that are available, which is like electrothermal debridement or reducing or shrinking the collagen, or shaving it, like it may be a partial resection or a complete resection. Then widening the notch, which is the main reason for the impingement and causing pain and restriction in the range of motion, or total excision, which is to be very carefully dealt with, or leave alone if it is not the real cause for symptoms. Now, what does the current literature say? Now, the problem here is, in the current literature, there are only 75 articles which are available. And out of the 75 articles, only 9 articles give us the true picture of the entire nature of mucoid ACL and the treatment protocol. So I kindly refer you guys to have a look at this particular systematic review, which gives a clear-cut guidelines on how they have managed the mucoid ACLs. They have narrowed down to 9 articles, and the most important inclusion criteria is the patient should be followed up for a minimum of 6 months. It should not have any case reports. It can either be case series or a case study, no case reports. And the most important thing is it should not be a literature review. And out of these 9 studies, we have got 3 Indian authors. So we have some information about the Indian population. And these were a combination of retrospective and prospective cohorts. And all of the patients had associated, 55% had associated chondral lesions in Srivatsav group. In Dr. Vivek Pandey's group, 63% had chondral lesions, which can also be a reason for the pain. They had done arthroscopic debridement and nobody did ACL reconstruction. And in the Srivatsav and Pandey's group, the range of motion improved very well. The patient's pain improved significantly following the debridement, and the functional outcome was absolutely fine. But keep in mind that Lynn's paper, which was published in 2010, there is 48.2% patients, approximately 50% of the patients underwent ACL reconstructions. What is the reason? The reason is mainly because of almost near total resection of the mucoid ACL. So we have to keep a note of that. What happens to the laxity? The most important problem that you come across in laxity is when you excise more than 50% of the ACL, and we have to clearly prognosticate our patient regarding this. Now, in this systematic review, 40% of the patients had a positive Lachman, but it was asymptomatic. And 6% had symptomatic instability, which needed ACL reconstruction. So What does the international literature say? This is totally different. This cannot be extrapolated to our Indian scenario, but the international literature says debulking is definitely good enough. You will have a good pain relief with debulking. Beware of symptomatic instability, which happens when you resect more than 50% of the ACL, and it is particularly with respect to young active individuals. And you have to adequately prognosticate your patients on the need for a second surgery in case the instability is symptomatic. This is international literature as suggested by David DeJord. In Indian scenario, in my practice, what I think about is, in addition to these things, is the economic factor, because the patient pays out of its pocket, it's not covered by the insurance in majority of the cases. The patient's complaints, the patient has to understand the importance of rehabilitation, and you have to make sure that they understand its importance. And third most important thing is the patient's IQ level. Now, how to judge this? In our practice, we have two types of patients. One patient who is extremely compliant, understands what you say, and cooperates to your surgical management guidelines. The second one is group is you explain all sort of complications, DVT, infection, everything, instability, everything. The moment you finish your discussion with the patient will ask, "Sir, avladana sir, வேற எதுவும் மோசமா இருக்காதுல?" அப்படினு. So you have to be very careful, okay, which means if the patient says, "That's it, no other complication," it means that the patient has not understood your prognostication. And in such cases, it's definitely safer to do an ACL reconstruction. And that's why we have an article which has been published, and we have done selectively cherry-picked those patients who are suspected to be non-compliant, and we have done an ACL reconstruction for all these patients, and their outcome is totally good. So the take-home message is, doing an ACL reconstruction for selective group of patients with mucoid ACL degeneration is not a bad choice. You can definitely proceed with it. Thank you.
Thank you. That's a very comprehensive. When you choose to do debulking, can you give us the tips what to do or not to do?
Sir, we have to think about the triangular gap formation between the ACL and PCL. We need to define it. It is usually obliterated. So we need to make sure that the ACL, once you debulk it, it should not impinge on the notch. So if the notch impingement is not seen, it means that your debulking is good enough. Next most important thing is, take it through the range of motion, arthroscopically. When the range of motion is unrestricted, I think the debulking is good enough, but it has got a lot of inter-observer reliability, because for one surgeon it may look less, for the other surgeon it may look more. So you have to differentiate that properly and make sure there is no impingement arthroscopically.
Anything also you will see that there should be no lateral wall impingement as well.
Exactly. So you have to do associated notchplasty also.
And other one, what are the classical symptoms patient comes with which should give you a clue, yeah, this patient we are dealing with mucoid before MRI?
Correct. In my practice, I have seen that the patient has got lack of terminal extension, and the patient gives complaint of a vague knee pain, which does not correlate to any meniscal
Particularly
pathology.
in the posterior.
Exactly. Posterior knee pain does not correlate truly to meniscal pathology, but you have to keep these things in mind.
So clinically what I do, I just do hyperextension, and that's painful, and flexion beyond 90 degrees is painful.
Yeah.
But mid-range between 10 to 90 is painless.
Correct.
So that should raise the clue.
Yes, sir. Yeah.
So when you do debulking, you don't touch the insertions, tibial and femoral.
No, we should not. We should not.
When you have so high incidence of cartilage and meniscal lesions, and an average patient cannot really describe between instability and the pain, they generally say, and how much we have to be aggressive about dealing the chondral lesions when you are choose to do a debulking.
The opinion matters from surgeon to surgeon. So, because it's the patient's perception of pain and how they explain to us what drives us towards the decision making. Okay. So, if my opinion is, if you find anything abnormal, try to correct everything in one-shot surgery, because the patient should not come and blame you for the second surgery.
Any questions from the floor?
Thanks, Sundar.
Thank you.
Thank you, Shyam. Thank you.
May I now invite Dr. Sundar Rajan for root tear subluxation index and its significance.
Good morning, Chairman. And so my topic is about the medial meniscus extrusion and what we are going to do with that meniscus extrusion. I think all of us are aware that what is the natural history of osteoarthritis. We know that when you load the meniscus, it increases the hoop stresses across your meniscus and can result in the peripheral displacement of the meniscus, and it can alter the pressures on the cartilage as well as the root. And we know that once the root is get damaged, again, then more hoop stresses on the cartilage, again, then patients can go for an accelerated osteoarthritis. So these are all interrelated, so we don't know which starts first, whether root or sometimes osteoarthritis. So it's interrelated. Some cases, hoop stresses damage the cartilage first, and sometimes the hoop stresses causes the root tear. So this is the difference. So what is meniscal subluxation? The criteria for a subluxation of the meniscus was defined as the distance of 3 mm or more between the peripheral border of your meniscus and edge of the tibial plateau is called a extrusion or a subluxation. So the subluxation index means that it is associated with the increased cartilage degeneration in the same compartment, or it could be it is described as a distance of more than 3 mm, which I already told about it. So the ratio of the meniscus overhang to meniscus width in the mid-coronal and initial MRI, which shows that meniscal subluxation or an extrusion, it can be measured with MR sequence of proton density weighted images with the mid-coronal plane will give you the measurements. We know that we have to drop a line, perpendicular line along the medial tibial plateau, and another line to the perpendicular to the line to the medial meniscus which was extruded. Then you measure the extrusion. The biomechanical studies have shown that the extrusion of the meniscus relationship between the medial meniscal subluxation and the stress distribution of the joint. So whenever the meniscal subluxation, the extrusions happens or subluxations happens, the more stress is going to the cartilage, the second most stress going to the medial meniscus. So this can results in the interrelated roots and cartilage damage. And also you can see this diagram. Whenever there is a meniscal subluxation or extrusion is more, then there is a possibility is correlated with the more osteoarthritis. That means that when the grade of arthritis increases, the meniscal subluxation also increases. So the hoop stresses, as I already discussed about it, it can cause a meniscal extrusion. Again, it can put a more stress, then resulting in a root tear, then cartilage degeneration. Or sometimes a cartilage degeneration happens first before the root, then develops osteoarthritis, then it can go for a root tear. So it is always very difficult to say which started first. So only our point of interest is that what is the relation between the root tear and the meniscal extrusion, why we are all interested, why this whole half-a-day program is going on, extrusion and the correction of that meniscal extrusion. So we also did a study on a correlation of the factors affecting the meniscal extrusion and the medial meniscus root repair. I think for a beginner, and if you want to know what is the root tear, I think you can see that is the meniscus roots which is coming and attached to the your tibial plateau on the posterior side. Which whenever you see an coronal axial view, this is one of the classic sign of your meniscus root tear, and you can see that this is the typical subluxation which happens. You can see that is the your margin of the tibial plateau, and you can see that meniscus is extruded. That is the distance which you measure for your extrusion or on a subluxation. So whenever you see the subluxation, then you know that there is already a cartilage degeneration has taken place. And we know that once the root has gone out, the stress which is going into the tibial plateau is so high. So that's why we talk about the root correction to reduce the stress on the cartilage to prevent or slow the progression of the osteoarthritis. We know that we have enough evidence that anything which is happening in the radial tear or root tear, almost it's put a lot of stress on the cartilage. So the main objective of the root repair, we know that to reduce the meniscal extrusion as much as possible, and it reduces the osteoarthritis. That's what we all expect to do a root repair. So whether what the literature says, when you do a root repair, does it correct the extrusion? Still, it is a lot of controversial topic. As you see here in the down, there are some studies which showed that definitely it is possible to correct the subluxation or extrusion, like Kim and Lee and Jungadal have published. And some studies have showed that the extrusion is not, correction is not possible even if you do a root repair. And there is some meta-analysis that have shown that there is no change in the meniscal extrusion even after doing the root repair. So it's very controversial. So this study which we want to know that whether these, what are the factors which is going to give a good prediction or a prognosis to have correct the subluxation or root, and also you want to know that all the meniscus roots are healed healed or not, and whether it's an anatomical or a non-anatomical position. So none of the studies have correlated these findings, which like age and what is the angle of hip axis of the joint, and what is the grade of osteoarthritis. Does it changes the your root healing as well as the meniscal subluxation. So as already told, that these are the signs which you see the root repair in the coronal axial view, you see the root tear, and also the ghost sign which you see in the sagittal view. So all these factors shows that these patients will have a root tear. So our series, we had around 54 patients. The age varied from 28 to 68 years. Mean age was 48 years, and follow-up was around for 34 months. And most of them predominantly female. That's what the healing shows. This you can see that some cases which showed the healed meniscus with the good correction of the extrusion, which you see the above film is the healing of the meniscus. The down film, which is the pre-op and post-op, you can see that there is some correction of the extrusion. On some cases, we had a partial healing, and some of them are hazy, very difficult to identify. It's very difficult to get hold of that healing in the MRI also. So some cases where the meniscus is healed, but there is an extrusion, increased extrusion of the meniscus. So in these cases, you see that even the alignment is normal. So we see that when you see the correction, where when I compare the pre-op and post-op extrusion, and this is the 34 patients had a good correction or extrusion, and 20 patients had a no correction or a more extrusion in the post-op. So in the patients who has got a more than 50 years showed that increased extrusion in this series, and you can see but irrespective of all this extrusion, even that the more than 50 years age group, the scores doesn't make huge difference whether the all the patients are almost same. And when we correlate the other symptoms like a duration and age, and you can see that patients who had a less than 50 years and alignment is less than 2.5 degrees of errors with the grade 1 and grade 2 I-series grade had a definitely better correction of the extrusion. At the meantime, and these patients had a better scores than the other group. And we can see the other, the patients with the good healing and anatomical tunnels had a good correction also. So the tunnels which you make an anatomical tunnel with the good healing of the meniscus also gives you good correction of the subluxation of the meniscus. And also this is done with the intra-observer's reliability. And you can see that anything age more than 50 years showed poor correction of the meniscal extrusion. There's a lot of, that may be a loss of plasticity. And these are the studies also had shown that root repair restored the peak contact pressures close to the normal. Ultimate goal is to restore the joint mechanism and to slow the progression of the osteoarthritis. Even our studies had shown that good correction of the extrusion is possible with the younger age. And the limitation of our studies is because it's a lower power of studies, only 54 patients. We had done MRI only at the 6 months. Maybe we don't know we have to see the later years, what happens after 1 year, 2 years with the further follow-up is necessary to do that. This is the technique, whether extrusion correction, apart from root repair, whether doing an extrusion correction will gives more results, we don't know. We don't have still enough literatures. To conclude, patients younger than 50 years with low-grade cartilage, that is ICRS 1 and 2, and alignment less than 2.5 degree of Ferris had a better functional outcome, and extrusion correction was possible. And the correction of the extrusion, progression of extrusion did not influence the clinical outcome on the short term, and progression of meniscal extrusion is inevitable even after successful repair in elderly patients and high-risk patients. Thank you very much.
Thank you, Sundar. This extrusion is only posterior and mid-medial. The anteriorly, we see very many times the meniscus is flowing out of the condyle even without symptom. Does it correlate with the root tear and the repairs, the anterior third of the meniscus?
I don't have enough evidence or experience to say that it's influencing the root tear or increase the progression of the osteoarthritis. So what we know that most often what we see that you see the middle of the mid-medial. So that is the mid-coronal view. That's what we correlated. We didn't correlate these anterior extrusions.
When you do a root repair,
Yes,
do you check for the mid-medial extrusion correction? If it is not fully corrected, would you put another anchor to pull it towards the middle?
In this study, we have not included any of those, but I started doing now for a few cases, which we see that in extrusion is more than 3 mm or 5 mm. If it is significant and the cartilage is really good, we started doing the extrusion correction, and also I'm doing one more study comparing that also.
Have you ever tried, instead of putting that centralization anchor, to do release of the capsule on the tibial side and just getting it in?
That is for a root repair.
Huh.
Root repair? Yeah, even if we do the root repair, still it may not correct your mid-cornal extrusion. So that is mainly to help you to get back your anatomical tunnel positioning and repair of your posterior root. So again, intraoperatively, that may not correct your mid-coronal extrusion. So you may need to put an anchor. So that's what is very controversial. We don't know that is going
We saw that as live yesterday. Bhupesh has exactly demonstrated that yesterday in the first live surgery. Any comments from Bhupesh you want to add for that question?
Centralization.
It's a good procedure, sir.
Very clear answer.
Any questions from the floor?
Definitely, there's I think we have a lot to answer in that. Actually, there are good opportunities to do more studies with the centralization and without centralization. So I think still literatures, I think it will come in another 2-3 years, we know.
So root repair plus centralization.
Yes, sir.
Always.
I was also the same opinion as sir. It might not work, but after seeing Bhupesh's demonstration yesterday, it sat so well and his technique.
No, I never say it doesn't work out.
No,
I don't know if it makes any difference or not. So that I think the studies will show, comparative RCTs will show.
Yeah, I thought it will fix the meniscus more, but the technique which Bhupesh showed, the mobility of meniscus is still there. So probably we'll have those videos posted in the academy. Everybody can see and then decide whether it's required or not.
There is no study right now to prove its efficacy, but I think with literature support in the near future, we'll have good evidence.
Thank you, sir.
Thank you.
For 2 minutes, we'll go back to the theatre.
Okay.
Bhushan just wants to show the final picture. Jayendra?
Navin, don't open anything.
Bhushan sir,
Okay.
we are with you, sir.
Okay. So we have done the necessary changes to the screw length. Can you see the images on the screen?
Yeah, we can see
AP and
that.
lateral view.
Yeah, we can see that very well. Do you have a CM picture of the
So
latest?
that's the surgery done. And
Okay.
in terms of the, so I'll just show you the position of the root tunnel. Take this off. See the root tunnel?
Yes.
Anybody here? Zoom
Yeah,
in
we-
here.
we can-
Zoom in here.
Outside picture, please.
Yeah, we
We
can
got the
see
root
that.
tunnel without any problems.
Hmm.
The posterior screw is about 30 millimeters, which is not bad at all. Now we're just going to tie the button and we're done. Okay, we're signing out now. Thank you very much.
Thank you.
Thank
Dr.
you,
Bhushan.
thank you, Bhushan. I think you will not have a hinge fracture hereafter. You can remove the hinge wire before you go off.
Sure.
Thank you.
Thank you very much, Bhushan. Thank you. Sir, you can carry on.
Okay. We have the privilege of inviting Dr. David Rogen
Hold my
to talk about the meniscus in a aging knee. Probably he is the best person in the world to talk about it. 40 years of his life dedicated to preserving the meniscus.
Thanks for the introduction, Sivanam. Really happy to be here, and so many of you, and so much knowledge to be shared. Congratulate Santosh and the team, which worked very hard to put up this show. And yeah, I'm going to give the talk from my experience and from what I feel rather than evidence-based. I hope you will excuse me. It's a very common occurrence in meniscus tear in the elderly. Very often they may not have any actual symptom like pain and locking. To me, a lot of patients come with the MRI, they're ready for surgery. Because in the periphery, they wouldn't have been taken even X-ray. But MRI, they have the MRI in their hands. I have a meniscus tear. I've been told to undergo surgery. So I examine them and take an X-ray, and if they are asymptomatic or occasional pain, and I just tell them, leave it. Sometimes a lot of patients are not happy about it because they come in bags and baggages for surgery. So all meniscus tears are not symptomatic. You don't have to do surgery on them. Just conservative treatment like icing and strengthening and prone exercise, which I am a great believer in, and will take care of it. The only indication where you have to take it seriously is when there is pain and there is a locking. Then you have to take it seriously. So this is a kind of MRI picture very often patients come with, and the report says it's a tear of the middle meniscus, and you can see much of the articular cartilage is good. So these patients, I just reassure them and don't operate on them. These are the kind of MRI pictures which may be symptomatic. You can see the complex tear and good articular cartilage, some contusion there, and there may be a flap tear which may be symptomatic. And then you have to think in terms of surgery. Very often, I also see patients with a picture like this, no X-ray taken, surgery advised. That is wrong. You have to have a weight-bearing X-ray, alignment X-ray before you advise the patient any surgery. That's a must. Otherwise, you'll have a very unhappy patient with you, because you've done a wonderful work of meniscus surgery, and it's a varus alignment and grade 2, 3 also, and they'll keep coming back to you, and if and when they need a replacement of the knee, they won't come to you, they'll go elsewhere. So displaced meniscal fragments, full thickness vertical tears, sometimes associated with ACL tear, which also may not be symptomatic. It's usually in horizontal tear. There may be repeated activity develop into a flap of the middle meniscus and displace or block the peripheral edge. Sometimes you can see in the MRI, in the flipped meniscus tear, which is symptomatic, and then surgery will be necessary. Then you can advise them very confidently, they'll definitely improve. So have a look at the MRI, see what kind of tear it is, and treat them conservatively in the beginning. Unless it's obvious tear which is locking and unlocking, there is no real need for arthroscopic surgery at all. So displaced meniscal fragments, full thickness vertical tears. Oh, same things again and again. Okay. You can see again a few more examples. On the left is MRI picture with flipped into the gutter. And on the right you see arthroscopy picture. This actually would have been hiding underneath the meniscus. A novice surgeon can easily ignore it or miss it unless you probe it. When you probe it, the meniscus fragment underneath comes out, and then you just have to do debridement of the meniscus, make sure the periphery is stable, and leave the patient alone. Meniscus cyst is also another important category where the meniscus can be very painful for some patients. And then also, it's usually younger patients, not elderly patients. And you do arthroscopy, cyst decompression, and meniscus repair. They do well. Just an example of a hidden tear, which you can miss easily. You have to probe it and excise the meniscus. Here, arthroscopy is definitely indicated. Root tears, we had more than enough since yesterday evening. And since I have the time and also root, and I don't know whether how good you are, how good it is when you do give a meniscus centralization stitch with an anchor, like my friend was doing it. And I think it doesn't move medial lateral post-operatively, because Freddie Fu is the one who told us long back with the MRI study that there's a lot of movement more in the lateral meniscus than the medial meniscus. Well, I have a feeling that we hope we can do some experiment on it. I have a feeling that the middle anchor will get ripped off after a few cyclic loading. Another thing is you are covering the entire middle compartment with the meniscus by bringing it so medial. And it is the lateral meniscus which covers more area of the condyle, not the medial. So that's something non-anatomical. Scanogram, I think that is the importance of scanogram. This is a new scoring system for meniscus tear to predict the repairability. I'm sure some of you are aware of it. And so these are also some of the tricks and tips that we have added. In a younger patient, when the degeneration is not significant, you can repair even a flap tear and put it back like crown feather technique, which was devised by Santosh. Just an example of repairing even a flap tear, which is a significant younger age group, and make sure there is no degeneration. So whenever you excise a flap, eventually there may be a horizontal cleavage tear. You cannot leave it alone because that will form a cyst or pain. So we also developed this technique where we close the gap by inside-out passages. So this will say that weight-bearing X-ray is a must. Don't miss it. If you try to do meniscus surgery in a patient with wrong alignment, more than grade 3, 2+, you will burn your fingers. So just to give the importance of scanogram. So post-surgery, a few tips. Mobilize the patient early. Don't make the patient lie down. And you have to counsel properly. Like you tell them 100 times. This morning somebody was saying, Sham, you tell them 100 times, we are not curing you completely. We are buying time. We are preserving your knee for a few more years. And after all that, after 6 months, the pain is gone, almost 80%, 90% gone. There's a little ache and pain. They come and say, you did the surgery, and we are still having pain. So prepare the patient adequately. Put it down. And when you find a patient who is not that very well informed, get hold of the son who is in Bombay or in US. He'll come for the surgery and demand all kinds of things. These are typical problems. So counsel them properly. I mean, you don't think it's a waste of time. Just an add to what I've been talking about. Whenever you do meniscus surgery, if at all you do, and you make sure there is no patellofemoral osteoarthritis. If there is patellofemoral arthritis, well and good, do lateral release, and the patient is very happy after that. So take-home points are, it can settle down on its own icing, exercises, walker, because usually there may be some bone contusion also. Scope and surgery only if indicated. And never forget to check the alignment. And counsel the patient pre-op well so that they won't come and sit in your OP and waste your time. Thank you very much. Thank you. Thank you.
You have titled as a meniscectomy. That was a forgotten word nowadays, balancing, suturing, debriding, all that. So how much the practice has shifted from meniscectomy, I mean not total, the partial meniscectomy to repair in your current practice?
No, we are talking about the elderly patients here. Huh? Here you've got to be very selective when you repair. We do repair. Very selective. Make sure the knee is in good health, the patient is well understanding, and the tear is not reasonable, then you can do meniscus repair. Otherwise, youngsters always, all the time, meniscus repair whenever possible. Because nowadays the patients themselves ask.
Sir, in these elderly patients, they are degenerative tear with arthritic component also. Definitely locking symptom is one of the indication to do meniscectomy in elderly. How you counsel them regarding pain management? How much they will be benefited with the pain? Only with meniscectomy, because there is already some arthritic component also.
Yeah, it's a good question. Even recently we had one elderly lady from with the locking. I think much alignment was reasonable. Alignment is the key.
Okay.
And otherwise try to send your patient to your neighbor. So that you take out the loose body and the exercises they do well. And the meniscus torn, just debride, not to do meniscus use cutter also may not be necessary. Very rarely necessary. When it's necessary, do it. And if it degenerates, don't try to repair.
Okay. Nowadays we have so many cocktail injections available, particularly in aging knee. When we have touched debrided the meniscus, do you think it will have a complementary effect if we can add on one of the injections post-operatively?
I can try it pre-operatively. Post-operatively, I am not very fond of it. Pre-operatively, you can try. You can say cortisone injection and see how they fare. And if they don't do well, then you can do it. So it depends on the age factor, depends on the patient's profile and what they will accept or what they will not accept. And consider all that into the picture and they decide and advise the patient accordingly.
Any questions, clarifications from the floor? Thank you, sir. That was crystal clear.
Thank you very much. Thank you all for coming for this meeting. Thank you very much, especially those who came from overseas, Stefan. Thank you.
May I call Bhupesh for root repair, when not to do it, and tips to visibility?
Thank you, chairpersons. Thank you, David Rajan sir, Santosh and Sham for inviting me. So, when not to do. So, this is a 46-year-old lady with left side root tear. As you know, if you see the alignments, the left lower limb is in varus. So, isolated root repair for her is going to fail. So, the right thing to do is to go in and do a HTO with the root repair. So, literature says asymmetric varus of more than 3 degrees, you have to do both the procedures together. So, here single procedure will not work. Another lady, she is 76-year-old, bilateral root tear following a fall in the bathroom, which was 6 months back. Now she has left more than right knee pain. You can see the meniscus is extruded, ghost sign is there, and alignment and knee for 76 year looks okay, but it is more than 6 months and she is 76-year-old, and because bilateral knee is involved, you are worried. So what do you do here? So the take home is, as per literature, so this patient went on to have a very happy uni on the left side. Whenever ICR is grade 3 or 4 chondral damage, then you're not going to do this. Go for replacement surgery. And post-op poor compliance should be anticipated, and this will be a prognostic factor. So 76-year-old bilateral knee pain, poor post-operative compliance is going to be there because she will not be non-weight bearing. So this is another indication to not do root repair. This is another case, 64-year-old professional. So he had a left knee root tear after a fall from cycle 1 year back. Now the important thing is he had multiple intra-articular injections. He had around 7 to 8 injections, steroids, PRPs, IL-1s, everything. So when I saw him, he had a synovitis knee kind of a picture, although MRI showed root tear. So I had counseled him for arthroscopic synovectomy, and when I went in, I could not help myself also do a root repair because the root was there. I did a synovectomy. It is hardly going to take another 20 minutes, but I know it is going to fail, and it failed, and that became a TKR. The synovectomy was done so that the TKR becomes successful and not for pain relief. So this is another contraindication. Poor tissue quality should be anticipated when multiple injections are given, and arthroscopically assess poor tissue quality, and that is a contraindication for root repair. Now, these kind of MRIs, again, poor tissue quality, subchondral cyst, meniscus completely extruded out, these are again contraindications. So, another contraindication is limb deformities. Whenever patient has got limb deformities like this, going in and doing a root repair does not make sense. Now, this is another patient. So, here you have medial compartment narrowing with Fairbank changes there. Now, that is definitely a contraindication, and literature says that although there is root repair, root tears in these patients, medial joint narrowing of, sir, next. Okay. So, medial joint narrowing is a problem. As David Rajan sir showed in the other talk, don't only look at the medial joint space, also look at the lateral view and the patellofemoral joint. So these are again contraindications. So medial joint space narrowing with Fairbank changes, asymmetric varus alignment more than 3 degrees, ICRS 3 or 4, limb deformity, obesity, poor post-op compliance, poor tissue quality, all this will be contraindications for root repairs. Now, tips on improving visualization, we saw this yesterday during the live. So this is something that I've been doing for quite some time. You want to see the posterior root, so with the probe, assess the depth of the posterior root, pinch your probe there, have a horizontal to that place, and then take it out, and then place it on the medial aspect of the knee. Take your marker, make a point there, and then all you have to do is go around a centimeter to 1.2 centimeter from that spot. Now, if you want to open the junction of posterior rod and body, you will have to place the probe there. Whichever part of the meniscus you want to open, you just place it there, and you can see with just one single prick, the medial compartment opens, and this is femoral side, so hopefully it will heal well. This is hopefully will be published soon, and that is a tip to improve visualization for the posterior rod. And sir, play, yes. So a few tips and tricks on that. You can also do it by Dr. Bancha's technique, using the magic point like this. So whichever suits better, please do that according to you. But the technique was pretty standardized. Remove a little bit of synovium there so that you have 2 access routes, one for the instrumentation and the other for visualization. So you bring the scope through the notch, so you can visualize it on an end-on view like that, and your instrument will come through the black arrow, which will help you in taking bites. So freshen the meniscus little bit, because biology is the key here. Then you can bring in your scoop. And this is the mild release that you can do in the junction, and then bring in your curved curette or scoop and then create some biology there. Bring in your root jig and drill an anatomical tunnel, and then come in with your 4.5. Always protect your bead pin with your curette, and you can take bites. Now we have all slowly shifted to the tapes from the sutures because the pull-out strength is better. You can cinch them or you can not cinch them, that is entirely up to you. And then shuttle them inside. Now after the root repair, when you see uncovered tibial plateau rim like this, that is when I'd like to put in a centralizing stitch. After minimal elevation there, plant this on the periphery through the mid-medial portal like what was shown yesterday in the live surgery, and then take the sutures outside through the capsule. This is like a Bankart repair, but a mattress kind of a repair. And you can see this is in the meniscocapsular junction, not through the meniscus. And always the bite should be anterior to the suture anchor so that you can pull the meniscal tissue posterior and take off the load from the transtibial stitch. And as you reduce and tie that, you can also tie your centralizing knots, and the uncovered tibial plateau usually will fall back and the meniscal extrusion can be corrected. Of course, we need long-term follow-up and good studies to prove it. Thank you.
That's quite nice and informative, Bhupesh. Good.
So the balancing, I mean, we already discussed about it. How often you are doing it when you do a MMRT repair?
Centralizing stitch?
Centralizing, sir.
Sir, it depends on the chronicity, sir. When it is acute, usually I don't do it because the reduction is fantastic. But in this case that I showed, it was chronic, and then even after pulling down, you see the meniscus is not happily sitting on the tibia. That is when I tried to do it. But I tried to not take the sutures through the joint and stabilize the meniscus there, because the meniscus has to move a little bit, so it is always from outside through the meniscocapsular junction.
Any medial side discomfort patient have after that?
So I've been doing this since Koga put his initial video in 2018 in Arthroscopy Journal. So 6 years I've been doing it. I have not seen any problems, but I have not done a proper study to report my this one. But patient complaints is good. They are not unhappy.
Yes.
I have one question for you. If you say the contraindication are obesity and low compliance rate for unloading after the procedure and bad soft tissue quality, do you think you present us a very beautiful picture for centralization? Do you think in the future, if we go more for centralization fixation, that we can support even in these cases the root fixation, especially if we have a bad soft tissue and if you have a low compliance rate? Do you think we can support it in these cases?
So thank you for the question. Obesity, yes, you can support with centralization because it is mechanical, but poor tissue quality is not going to change. So poor tissue quality will definitely be a contraindication even if you do a centralizing stitch. Because even if the centralizing stitch works, the meniscus has to take the stress and the hoop stresses has to work. So poor tissue quality will be a definite contraindication.
Thank you, Bhupesh. Thanks a lot.
Thanks, Bhupesh.
Dr. Santosh, for isolated patellofemoral OA, joint preservation strategies.
Yeah, I'll try to catch up some time here. So probably this area of the knee is something which we've been ignoring or ignored, where there is an isolated PFOA, but main joint looks okay. You cannot ask them to go on and do a joint replacement, but patellofemoral symptoms are bad. So what exactly to do? We cannot offer much surgery, but there are few options which are coming up, very selective indications. To get an idea of what it is, to give an overview, I'll just show a series of 7 cases which will give us an idea. To know what is patellofemoral arthritis, this classification gives the stages where reduction of the patellofemoral space alone, this classification helps us understand the patellofemoral arthritic changes. A merchant's view X-ray is one which you need to make sure you know what's the stage. A lateral view also will help us know. So let's see the case series. I'm not sticking to the arthritis here, just to give an understanding what we are talking about. This is a case example of a young individual. So talking about patellofemoral changes, patellar instability is one of the most common cause for developing arthritis at a later age. So addressing them early as a prevention. If you have a dislocation and if there is a loose body and it's a large significant osteochondral loose body, try to fix them early. So when you're fixing them early, you are preventing an arthritis later on. So if there is a significant loose body, try to fix it and salvage the loose body as much as possible. There are a lot of techniques which are there. You can use pins, you can use such kind of threads where you fix these osteochondral loose bodies, restore bone as well as the native hyaline cartilage. You will definitely prevent a later on arthritis and address the primary pathology by reconstructing the MPFL or whatever is required. This is to start with, but let's see the case 2 where the age increases, and as you can see in that where exactly the patellar lesion is. If it's a patellar lesion in the medial facet like this, and it's a low demand patient, you are going in for another procedure. I'm not saying this is an indication for surgery. When you're going in for another procedure, if you find this in a low demand individual, you can still stimulate this by doing microdrilling or microfractures. But microfracture in a patella is slightly challenging. Microdrilling, the outcomes of microfracture in patellofemoral joints are not great. Probably because we do it with microfracture with bigger awls. Microdrilling are better, but how to access this part of patella? So for microdrilling, this is a technique which we've tried where you raise the leg up, try to come through the gutter and pass multiple drill holes. That's a small tip. I'm not saying this is an indication for surgery. When you're going in, when you find out such lesions, do not leave them. You can still do a microdrilling and enhance healing of those kind of cartilage in a middle age or an elderly age group. That was for the medial facet. What about the lateral facet? Lateral facet, this is a high demand individual. It's a basketball player. I'm again going back when we see them early before they develop arthritis. It's a total thickness loss of lateral facet. When you see them, you cannot leave them. You have to address this lesion. So what are the options available? If there's a full thickness lesion like this, there are cellular options. In India, we have BMAC and ACI. Here, ACI will be a 2-stage procedure where you harvest the graft. If it's a high demand individual, it's better to do an ACI, where this is the patella. Patella is placed in a dependent position, and first layer of gel is placed. To give a good contour, we pass the needle under the first layer and then bloat up the layer so it forms a convex contour. It is done under dry scopy and it should be in a dependent position. So how to make a patella in dependent position? For that, Renaud Seabolt has got papers. I learned it from him. So you can do a prone scopy. As you see, normally patella is up. Here in prone scopy, patella is down. So you clean up it, make it dry. For dry scopy, this is done without air insufflation. You just need those cannulas. You need to open out your outflow cannula so that air can come in and your suction cannula can take out the air. Drilling is done before that procedure. So another case, if it's a same basketball player, a cartilage defect, And when you see the lateral view, it is the patellofemoral area is the area when it comes into contact around 20 to 30 degrees. That's the angle which she has pain. So when you do a cartilage procedure, there are options to unload this also. So to give a thought of unloading procedures for patellofemoral joint. So there are unloading. We've seen all about osteotomies, about high tibial osteotomies and femoral osteotomies. There are unloading osteotomies for patella, where if the patella is high, you need to bring it down, and it depends on when they engage, which part of the cartilage defect engage at what angles, and whether it correlates with their symptoms is what you need to see. In this case, the TTTG was high, so it was we need to correct that also. When we need to correct it, we can unload it also. So it was a cartilage procedure combined with an unloading osteotomy where it is antromedialization. So there are various procedures. The options of medialization or anteriorizations are these, where it's Fulkerson, McKay or MC Trillat. AMZ is what we did. It is antromedialization. I'm not going into the details here for want of time. So you must be aware of those kind of osteotomies which unload the patella. So those are meant for younger age group. When we come for more of arthritic patella, as in such cases, when you're going in for a meniscus procedure, you do the meniscus and you find this in the lateral facet of the trochlea. So it's lateral compression syndrome. So the patellofemoral joint in the lateral side is tight. Clinically, you would have evaluated them. The patellar glide would have been less. Patellar tilt would have been tight. If those were there, then you can add a lateral release. So you do a procedure of micro drilling for that, and you add a lateral release where it can be done with the radiofrequency hook, where you cut the deeper layers of the retinaculum. But a slight controversy whether you do this in an uncontrolled manner or a controlled manner. A lot of evidence are emerging where lateral lengthening is better than doing a lateral release alone. Where if you do aggressive lateral release, you might end up with medial instability. So a lengthening procedure would be better, especially in a younger age group. When it is arthritic, I believe lateral release is good enough. So going on, just going out of the way of isolated patella, you must be aware when you have a patellofemoral arthritis and you have a varus. Our series have shown osteotomies. It's a high tibial osteotomy, but a descending type of a. Normally, our second biplanar osteotomy limb goes up behind the tibial tuberosity, but you can see here this is a descending type of high tibial osteotomy. If there is a patellofemoral OA changes, when you do a descending type of osteotomy, when you do a varus correction, the tibial tuberosity does have a medialization, and to some extent if your cut is oblique, it can have an anteriorization also. So a minimal anteriorization is possible with the descending type of osteotomy where patellofemoral unloading is possible. So one of the indications for a descending type is a low patella and early patellofemoral OA, as you can see in these graphics. So again, you must be aware of the valgus, lateral facet overloading with valgus. If it's in the femur, you have the option of doing a distal femoral osteotomy. And the last thing, if the facet is tender, clinically it's the lateral facet or the tip osteophyte which is giving symptoms, and that's the only symptom for her. Probably a facetectomy would be a procedure of choice. So you must be aware of these things which are available and choose the right patient for the right way of treatment. Thank you.
Any questions from the floor? It's a very, very difficult to choose the patient with the clinical assessment only you can do. Thank you, Santosh.
Thank you, both of you. Thank you, sir. So we're running late by 10 minutes. We'll start the next panel discussion. I invite Dr. Geethan onto the stage for the panel. Thank you, sir. So I call upon our